Welcome to,
And then they wondered.
where we are talking about hospice, end of life, the dying process.
That's right. In this series, we've been covering hospice care, but today we're specifically going to talk about end of life symptoms.
Yes. So have you ever wondered, what does a dying process actually look like?
And then they wonder, what does it mean to live and to leave?
As hospice nurses, we have seen time and time and again what normal looks like, but for family members, for the patients themselves, this is a time of, is this what this is supposed to look like? It can be kind of confusing, a little bit distressful. So we're going to walk through the body parts from head to bottom.
Symptoms you're likely to see. The reality is, death is a natural process. It's a natural part of the life cycle. But when these symptoms happen, they can seem scary because a lot of us haven't lived that part of the life cycle yet, unless you've worked with death a lot. You haven't seen it all. So these symptoms will vary likely person to person. You may have all of them or none of them, or your loved one may have a lot or just a few or none at all. Everyone's different. But this episode will prepare you for what you might see or experience if you're taking care of someone who's passing or at that end of lifetime.
Yep. So disclaimer, you may not see them. They may not be in this order, but we'll just go ahead and dive in.
All right. So to start off with, we go on head to toe. We usually start to see changes with people's thought process and sleep patterns, things like that. Do you want to talk about that?
Mm-hmm. So the first thing that we often see is sleeping more. So increased sleep will occur. A lot of questions that we hear: why is my loved one sleeping so much? Or they're not sleeping at the quote unquote right times. You'll just see them start to sleep 16 hours, 18 hours, 20 plus hours. And that's part of the body kind of has one foot in the present and the other foot in the next world to come.
They'll start being a little bit like a newborn.
Yeah, exactly. That's a good way to put it. The next process that you'll see is some confusion and hallucinations. There's a lot of seeing loved ones that have already passed, a lot of confusing remarks, for you as the one taking care of the person passing or for the person themselves. Questions like, why is that person in my room? Or I don't recognize you. Mostly seen in like dementia, but can be seen in just the regular dying process.
Mm-hmm. Yes, that seeing people who you've known before or experiencing seeing things that aren't there is really common for a lot of people. And also really vivid dreams. They'll wake up and think something happened at night after they were sleeping that didn't happen, or be confused about where they are, things like that. All right, moving on from changes with the mental process, we're also going to often start to see at end of life, especially at the very end of life, changes in breathing. Oxygenation. In our last episode, we talked about morphine and the use of morphine to manage the problematic symptoms of breathing. But specifically today, we want to talk about specific changes you might see, because this is one of the main things that people find alarming when the breathing starts to change. So one thing you're going to see a lot of times that does need to be medicated is labored breathing, where your loved one maybe starts to breathe and you see they're using muscles, using their rib cage is kind of flaring out and they're using their belly muscles to breathe. You can also see
tense belly movements you'll see.
They're not just it's not just a rise and fall of the chest. You're actually seeing they're having to work effort of breathing. What are some of the other breathing changes we might see?
Other breathing changes, this will be a little bit more closer to the end, will be what we call Shane-Stokes respirations. And essentially what that means is respirations will be really, really fast, and then they'll be really, really slow, or really, really fast. We're not breathing for 10, 15 seconds, breathing really, really fast. And it's a little bit of a pattern that can be very alarming, especially when the moments of no breathing are longer and longer and longer. A lot of times people will say, well, I just saw them breathe their last breath, and then a minute later, they go back up again. So that can be a little bit alarming, a little bit distressing, but just know that that is actually normal.
You might hear your hospice nurse call it apnea, which just means pauses in breathing. Just they're taking longer breaks between breaths.
That's right.
It's very normal. Also, it may sound differently. You may have some changes in just the way the breathing sounds, almost like a snoring sound or some things like that.
And that's not something that needs to be medicated. Actually, the breathing change, especially with the moments of not breathing or the apnea, that's not really something to worry about. It's really like labored breathing that we really do want to.
Labored breathing, grunting with breathing,
Yes.
signs that they're struggling.
But some snoring is okay. You know, some moaning every once in a while with the breathing is also fairly normal, not something that we really want to treat. So that's just an example about the breathing changes. The next we have appetite changes.
That's right. And this is one that, depending on the disease process, might change sooner because, for example, like CHF, like heart failure patients or people with lung failure, they often start to have problems eating a lot sooner.
Their reserve or their endurance for consuming a whole meal becomes more difficult.
Yes. They may have fluid that builds up kind of in the abdomen area, making it feel like there's less space in their stomach. And then additionally, eating is work. Bringing the fork to your mouth to feed yourself, it's work. So those two combined can really make it hard to eat. So in those scenarios, we often advise to just think less of eating meals and more of eating consistent protein-rich snacks throughout the day.
Yeah. And research does show that it's okay for the body to gradually stop eating. Don't force feed your loved one. That is probably the worst thing that you could do. If you try to force feed or force hydrate your loved one, actually could cause more problems than good. They can, choke actually because they're not really managing the secretions as well or swallowing as well, like we talked about in the previous episode. So that can cause more harm than good, force feeding. So if we just stick to smaller meals, whatever they can tolerate, if they get to the point where they're like, I only want to eat ice cream, that's fine too.
That's right. It's really clear in the research that when a body reduces its food intake, especially towards end of life, that the body actually compensates with endorphins, happy hormones.
Yeah.
That help with some of the symptoms of the dying process. It's, again, we're going back to that idea at the beginning of it's normal and natural and it's part of the life cycle to die.
Yep.
This is a normal part of life for us as humans. And our bodies are built to compensate for that and to help us with that process. And the decreasing appetite at end of life is part of that.
And it's a good thing.
It is.
Especially if it releases those happy hormones.
Exactly. And additionally, if you're passing and you have a lot of food or fluid, your body actually isn't going to be able to process that anymore. So it kind of just sits and starts to build up in the wrong places. And we start to have a lot of adverse effects. So allowing your body or allowing your loved one's body's appetite to decrease naturally during this process is important and a healthy part of the process.
And you will not be starving them.
Correct.
Which brings us to our next point, urinary and bowel changes.
That's right. Like we just said, the systems are changing. Things are not working the same anymore. So what are some urinary changes we're going to see?
You'll see a lot of very similar to UTI. The urine is decreasing. The urine becomes more concentrated and darker. The urine is not necessarily foul smelling.
It smells stronger.
But smells stronger. Yeah. So not necessarily an infection, but definitely the kidneys are not working to their full capacity. So when that happens, a lot of families and loved ones do think that it's just a UTI, but we have to pay attention to the other symptoms along with the urinary changes. A lot of times we will go ahead and prescribe medication for UTI, mostly to help the family, appease the family, and kind of, if I'm wrong, great, A lot of times, though, in my experience, we are only able to get like one dose of the antibiotic in before things really turn. So could it be a UTI? Absolutely. But if we take into account everything else that's going on, and that's kind of what your hospice nurse is trained to do, look at the big picture, and that's part of one of the changes that we see. Correct.
We'll also see leading up to someone's to that final decline, we often start to see changes in urinary continence, meaning difficulty making it to the bathroom in time, or even wetting at night, things like that. So there's some great products, Depends, pull-ups, pads, liners, things like that can protect the dignity of your loved one while also supporting them during those changes, because those are very common changes to see.
The other thing along with that point is increased. It looks like there's more urinary output because it's actually increased incontinence. So that's right. Another thing to kind of keep in mind.
Oh, that's a good point. Yeah. Another thing is right towards the very end, a lot of times your nurse might do a catheter or suggest a catheter for your patient, partially because of the incontinence. For some people, that can be really frustrating, irritating. Additionally, if the incontinence is kind of due to we are too weak to get up and get anywhere anymore, it can help protect the skin.
Yes. Very good point. Bowel changes is another one that is hard, I don't want to say hard to manage, but it's one of those things that's a little bit more, we want to preserve your loved one's dignity with that one.
That's
with
right.
urine and with bowel. So you are going to see same increased bowel incontinence, and you will see the stool begin to change a little bit. So we'll see either constipation or diarrhea a lot of the time. And so the constipation could be due, obviously we're not eating or drinking as much. The diarrhea could be due because of just normal, regular bowel changes that are occurring in the body's trying to push it all out. So those are a couple of different bowel changes that we see, but we never want to let your loved ones still, even if they are in the end stage, go longer than 3 days without a bowel movement. And like we talked about in the previous episode, we will use suppositories if needed. We'd like to avoid them, but sometimes it's hard to avoid.
It kind of works in combination of our appetite decreases and the body systems are slowing down. But unfortunately, that can lead to essentially dehydrated stool getting stuck in the colon. So we want to stay ahead of that. So if you notice the bowel movements are stopping, or like you said, you know, even if you get to like day 2 and we haven't had a bowel movement and this is going on, it's important to let your nurse know, because sometimes we can do something a little less invasive before we get to the really invasive options.
And the diarrhea typically tends to hit like when the bowels are trying to...
They're evacuating everything.
Yes.
They're like, this is the big clean out.
This is it. Yeah. Can happen or not.
I've had patients where the diarrhea is really the first sign of decline. It's like all of a sudden we just have this onset of diarrhea that's just sudden and unexplained. And then 3 days later, it's like, oh, that's what that was.
Yes, that is true. That's a good point.
Definitely.
Again, not in any particular order.
Exactly.
Anyway, next thing.
Skin changes.
Skin changes.
That's right.
So what you'll see with skin changes a lot is a little bit of pallor will start to set in. There's a term that we call mottling, and that's kind of when there's like little purple patches, I guess. Usually starts like in the knees, the arms,
elbows, nose and ears and around the mouth. It's very
under the
common.
eyelids. You'll start to see the like purple splotchy changes. Actually, you see that in newborn babies, which is a little unsettling, but it is a bit of a bell curve, as I've come to learn. And we have talked about this also in previous episodes, where you'll start to see kind of similar symptoms. And so the skin changes, the skin begins to thin out a little bit more. You start to kind of see like more hollow under the eyes, things like that.
And dryness, also like feet, legs, things like that. That skin can get really dry. Lotion is great. Doing lotion, especially after they've had a bed bath or whatever, doing that lotion can be good. And it can be a great comfort as well. So it's also kind of a means of comfort to do that. All right. This is one of the most, this is the thing that we look at, but we look at in context of everything else. Vital signs.
Vital signs. That's a good one. Vital signs is a good baseline for us to have. We don't always go by what this number reads. We will mostly go by how the patient presents. But the vital signs is a good indicator of where we're going and where we're headed.
In my experience, vital signs often lag behind. So your assessment as a nurse, looking at symptoms and looking at, especially if you're seeing a patient for the first time, looking at their notes and asking real good questions about where things were 3 days ago and what was happening 3 days ago compared to the changes you see today can often be a better indicator of what's going on than the vital signs initially.
That is true. But I think mostly for nurses, that's more important to look at than the loved one. I feel like a lot of times loved ones will drive themselves crazy.
They will. If they have like the
to those vital signs,
and they're just like watching and they're like, and the thing with vital signs is they don't go like straight down. Honestly, none of these symptoms typically are like a straight line down. They kind of go up and down. So you might check their oxygen at one point and it's 70 and then you check it again and it's 82. And so you just kind of put yourself on this roller coaster that can be avoided. Let the nurse check when they come. Really don't worry about it. And
it happens even to us, we'll put in our documentation on day shift, this person's declining, and then the night shift nurse comes in to see them. They're fine,
Yeah.
And it makes us look like liars, but not really, because we kind of understand what's going on.
You kind of know, and it's not, none of this is just a straight line of decline. It's just going to kind of go up and down and up and down and up and down. It's all a downward trajectory, but there's variations with
it. And it can happen very quickly. Like I said, even in one day, we can have a very quick turnaround. And I believe that we did talk about this in the last episode about the rally.
Oh, yes. Let's touch on that again.
Okay.
Because it kind of goes with these symptoms, because a lot of times what will happen is we'll have all these symptoms of somebody's confused. They're starting to have hallucinations. They've become incontinent at times. And then all of a sudden you have this day where it's like, they're themselves again. Mm-hmm. They are eating dinner with the family and having a great conversation. And then the next day they won't wake up.
Or they've gone. Mm-hmm. It's almost a little gift, the day of rally. So we see that a lot. And this is why we talk about this is never linear. This is just up and down, up and down, up and down. And then we'll have that one very good day when then they're themselves again. And then we're right back down to, or maybe even worse. Well, I hate to say it worse, because really this isn't bad. This is natural. And this is what's supposed to happen in the course of somebody's life. So then we see decline and living. Yeah. That's a good way to put it.
You kind of get that one big last like hurrah, which is nice. Yeah. Not everyone has that, but those who get it, that can be really nice.
That's right. Mm-hmm. So then we want to talk about, do we want our loved ones to be sedated and comfortable versus awake and miserable?
That's right. There does, for most people, unless it's something where they just have like a sudden cardiac event, that does happen to patients on hospice. But if they're following just kind of this decline over several days, there typically comes a point in the process where the pain is too great, the symptoms are too great for them to really be alert and interacting anymore, and also be comfortable. Those two become non-compatible. So you have to choose, okay, we actually, do we want them to be comfortable, or do we want them to be more alert but miserable? So more of that sedative level of medication will typically be required.
You see that mostly in people with cancer, some cancers, not all cancers. And
a lot of COPD too.
And COPD? Oh, yeah. Interesting.
I find with the air hunger as they're passing.
Yeah, that's a good point.
A lot of times to control the air hunger.
Yeah.
It's
I was thinking pain, but yeah, you're right.
This kind of leads into our next point, which is just younger people have a different process.
They do. Younger people have more of a more intact compensatory system than older people.
Non-medical English.
You're right. I'm so sorry. Nurse brain on, off. Okay. So younger people have a system that is able to make up for where they're declining. So it's kind of like a little, if you can imagine, like a bit of a seesaw. Mm-hmm. So, if we're going down in one area, it will go up in another. And within the body system, that is compensation.
Correct.
So I'm overcompensating for something that's not working as well.
Really? Because younger organs are just younger. They don't
stronger,
and they're not worn out. It's like the difference between a new car and an old car. If something goes wrong in a new car, you have the thing that's wrong.
Right.
But in an older car, it's all kind of worn out, and that's the way our bodies are.
And there's more of a little bit of a slower decline, whereas with a younger person, they're functioning optimally until they're not. And this happens a lot in kids. This is something that was really drilled into me when I was a trauma nurse or ER, but we had to go through the trauma thing.
Yes, for that trauma certification. Yeah, because that's the one where they can, if you're not really on it and watching, you're like, it happens so suddenly.
Yes.
Because their body's compensating. I'm using that word again. But like you explained it.
I explained it.
But it's just like all the systems are really working and fighting and have all this energy to fight. And they're doing a good job until all of a sudden
they're not. They're spent. So that's that. And that is more common in kids. But then as we talk about these processes, specific disease processes and end of line, that's more common in kids like in trauma. But I'm talking about like in younger, you can kind of apply it in younger patients with disease processes. That's how it's going to look like versus an older person with that same disease process. So we kind of see more compensation in younger versus older, like you talked about. This is a good example about the car.
The other thing we wanted to talk about was some things that we can do outside of medication.
Yeah. So, because all these processes are normal, so what can we do? What can you do at home to help them to become comfortable? Because some of these aren't necessarily comfortable.
Exactly.
Some of them are, like I said, like some of the breathing is really, it's fine. understand that they are not suffering, they are okay, and maybe a little bit of a reposition can help.
Mm-hmm.
Or maybe massage. So we do want to talk about the interventions that are non-medical that you can do for your loved one at home.
That's right. And we are a big fan of hospice comfort medications. You can check that out on our previous episode. You'll hear we're a big fan. We think you should use them. But when used in combination with some environmental things, can make a big difference. So
that's the gold standard.
That's the gold standard. The gold standard is we do both together. So
yes.
Some things we think about, like we're not separate from the room that we're in.
Mm-hmm.
So if the room that someone is in is very bright, very loud, has a lot of just stuff going on, maybe the TV's turned up really loud and all the lights are on and there's people running in and out, it's going to be really hard with any medication, your loved one to get comfortable, most likely.
Mm-hmm. Yeah. Unless that's the environment that they come from.
If they, I mean, maybe
I don't know. Yeah.
I've even had patients who, like, maybe they were used to having it all loud because were hard of hearing and things like that. But then even at the end, just
it's still too much.
Quieting down the lights, quieting everything down made a big difference in their comfort.
So that's something that you can do, change kind of the lighting, the environment. Music is a really big
music is a
good one.
It's a really good one, especially dementia patients. I mean, no matter where someone is in their process, even if they're not at the end, music can be really powerful. But playing their favorite songs, things like that, can bring a lot of comfort. Touch is another one. Like you already mentioned, massage, repositioning, getting that bath time. And one thing that I run into a lot, or have run into a lot, is that families maybe aren't turning their loved ones. And so then when it comes time to turn, we discover that the medication isn't adequate, which actually it's leading to more pain, because if you think about even just like sitting on a chair for 4 hours, how uncomfortable you get, it's just kind of creating this pain cycle. But if we are medicating enough that we can turn every 2 hours, we know we actually legitimately have comfort achieved. We've achieved comfort at that point. But if we're only achieving comfort if they're completely still and just kept in one position, that's not real comfort. So we want to be able to be turning them and repositioning and doing a bed bath and things like that. All of that helps with comfort. And the medication has to be at a level where we can do that.
Yes, exactly. Because then, if you're not moving for several days, things start to stiffen up. And if
now we have more pain.
That arm, then there's a lot more pain there involved. So we do want to employ both comfort medications and non-medication interventions.
That's right. It all works together. It's like a cycle. Like if we are repositioning, then we actually need less medication long-term. But if we are giving if we're not giving the medication, we can't reposition. So it all works together.
Yes. All works in tandem so beautifully.
Yeah, that's right.
Anyway, that's our episode. I hope you guys enjoyed it. I hope you guys learned a lot from it. And if you have any questions, stories that you'd love to share with us, please put down in the comments below. You can also follow us on social media or write us an email at andthentheywondered@gmail.com.
That's right. Thanks for watching today, guys. We will see you in our next episode. Be sure to like and subscribe so you don't miss anything. We'll see you next time.